Welcome to Grade 1 View, the podcast for future CRNAs by future CRNAs. A new series of Beyond the Mask supported by FAANA.
Whether you're about to graduate from a nurse anesthesia program, trying to get accepted to nursing school, or you're somewhere in between.
This podcast is a resource and safe space for all things nurse anesthesia.
We're your host team. I'm Kevin Chem.
I'm Olivia Kahn.
I'm Charity Garno.
And I'm Larry Sears. So grab your Mac or your Miller, turn up your flows, and get ready, because this is Grade 1 View.
Welcome back to Grade 1 View, the podcast made for SRNAs who want to feel confident about walking into the operating room. I'm your host, Olivia, and today we're diving into one of the most fundamental tools you're going to encounter in clinical practice, the ventilator. Mechanical ventilation, it can seem intimidating at first. It's got different modes, alarms, endless knobs and numbers, but understanding how ventilators work is essential for keeping your patients safe and for making the proper adjustments in real time. In this episode, we're going to cover everything from the basics of volume and pressure control to the nuances of advanced modes like SIMV and pressure support. We're also going to talk about troubleshooting, patient-specific considerations, and even maybe the future of ventilator technology and where anesthesia might be 50 years from now. By the end of this episode, you should have a pretty clear roadmap about approaching the ventilator, and I want you to have confidence when you're first ending your clinical rotations. And assisting me in this episode is our wonderful guest, Dr. Wilson. Just to give you a little bit of a background about him, Dr. Wilson graduated in 2006 from the University of South Carolina School of Medicine with a master's in nurse anesthesia, and in 2022 from the Medical University of South Carolina with his doctorate of nursing anesthesia practice. Currently, he serves as the assistant program director for East Coast of Ursuline College with Somnia Nurse Anesthesia Program. Before that, he was the assistant program director for the University of South Carolina and opened their second campus in Greenville, South Carolina. He's authored on the chapter on blood component therapy in the latest edition of Nurse Anesthesia and is published in JOPAN and the ANA Journal. In 2023, Dr. Wilson was selected as a fellow of the American Association of Nurse Anesthesiology and was recently elected to serve on the AANA Leadership Identification Committee and as an AANA social media ambassador. He continues to practice clinically and mentor future CRNAs through CRNA School Prep Academy. So welcome to Dr. Wilson. And I think it's just so awesome that I just kept saying the word South Carolina because I am moving there come January and I'm working for MUSC. So yay.
Well, first of all, thank you for having me, Olivia. Second, congrats on your upcoming graduation and moving to South Carolina. I think you will really enjoy it. I think you'll love it.
So excited. So excited. I mean, I love oysters. I love the smell of Charleston in South Carolina.
Oh, yeah.
So it's just it's that certain smell. I don't think there's a real good way to describe the smell, but it just feels like home to me.
Well, there's a lot of great things in Charleston. Just that whole beach feeling, that historic feeling that Charleston has. Just a lot of great things. I think you enjoyed, and obviously your friends will enjoy coming down there to see you.
I know. That's what I keep telling my my classmates that I've become real close with. Who I'm like, you people better visit me because I'm in prime state real estate. You know.
That's right.
All right. Well, let's just dig right into it. So, mechanical ventilation. When I first started clinical, even just before clinical, the ventilator was something that honestly scared me, and I would try to read in my textbook. I would try to read my lectures over and over and over again, try to find some YouTube videos. And I felt like there was not honestly a whole lot out there really helping just individuals like myself really understand how to work a ventilator and make it not so terrifying. So I figured we could just kind of start from the top and, talk about what is the primary purpose of mechanical ventilation and critical care.
Yeah, so really, mechanical ventilation has been something that's really interested me for years. And a part of that reason is through my academics and through my education. I'll kind of give you a brief story on that one. But really, as I was looking at ventilator modes, I graduated in 2002 from my nursing program. And in 2004, started my nurse anesthesia degree. But really back then, we were in a different set of kind of standards, different kind of things that we could do. Let's just leave it that way in the ICU than what you can do these days, right? I think you have probably felt that, and many of the listeners here felt that too. Back then we could make ventilator changes ourselves. We really worked with respiratory therapy on that to even, as part of my admissions committee responsibilities and talking with people, you find out now that really nurses get in trouble if they even get close to the vent just about, right? They really can't make the changes on it. They can't do all of the nuances that go along with it. So what I was finding was people didn't understand the ventilator as much as we hoped they would. And getting into anesthesia, as you know, and you've seen, man, there's a lot to do with that thing that we have to maneuver, play with, make changes with. And so it was probably about 10 years ago within our program, when I was at the University of South Carolina, that I started really doing lectures and presenting this information and saying, you know what, let's start, if we're going to have people really understand this and utilize this, we need to be providing education for them. And there was, as you said, there really was not a lot of education on it. So I started diving into it and really just started saying, all right, let's start providing the basics, the fundamental. Let's get people understanding why, when, how do you use all of this so that we could provide better patient care, but also so that our learners could feel more comfortable with something that's really should not be that intimidating, but it is.
Yeah, absolutely. I remember just walking up to the ventilator the first time. And I mean, and when I was in sim lab, they taught me on the Draeger Apollo. But then my very first clinical site was the Amida. And I walked in, I was like, oh my gosh, the buttons are different. They're different colors and there's different, like I just froze. And, now that I've gone through over a year's worth of clinical sites and I've touched way more ventilators than I ever thought I would. And the basics are still there. But every now and again, when I like flip back from like even like the Perseus, and then I go into the Amida and then I'm back at the Apollo, it just takes me a second to be like, okay, wait a minute, where's my footing? So I think this topic is so important and is really honestly the bread and butter about what we do every single day.
Yeah, and when you look too, you've got a lot of preceptors out there, right, that are maybe been out for 15, 20 years, maybe been out even longer that are there. And I can tell you just from personal experience, and we use the Datex Amida XLSE 210 when I was in anesthesia school. That is one that many of y'all look at and wonder if it's from the 60s, but really it's not. It's from the early 2000s. When I do my lectures on anesthesia gas machines, I'll show a picture of one and they're like, man, that's old. I'm like, be careful. That's what I trained on. But really, when you look at it, that had a separate ventilator all in itself. So the control was completely separate. It was not tied into the workstations like they are now with all the electronics. You literally could change the tidal volume and it would change the IDE ratio and you'd have to go back and readjust it. And there was only one vent mode on it. Volume control ventilation was the only thing that it provided. And so it was interesting to me because I was like, man, I just left the ICU where we were using, pressure control ventilation, SIMV. We were using jet ventilation. Yet now I'm back in this where I thought this was an upgrade. And I'm back to all I've got is volume control ventilation and hand ventilation. So that's really thinking about kind of the evolution of where this has all gone. It's really been interesting to kind of study it out all throughout the years.
No, you're certainly not wrong about that. I mean, there's been several times, even like during my CV rotation, when you have to take those patients from the ICU and they're on such a specific vent mode that my anesthesia machine can't actually do this mode. And so we have to bring down that ventilator that's, hooked up to them in the ICU and bring that into the OR with me. And now I have, a respiratory therapist who's showing me their machine that they're working with every single day. So it's not what I thought it was going to be when I first got started being introduced to the ventilator when I was in the ICU.
But when we get down to it and really kind of talking about ventilators, they really have two primary purposes. And it really is oxygenation and ventilation. And we really need to break it down that simple. I know that seems like, hey, that's just simplistic and that's way, we should be talking about stuff way beyond that. And believe me, we will in this episode, don't worry. But that's just the simplest part of it, right? Is we are providing oxygenation and we're providing ventilation. And we got to remember, oxygenation, which is purely just getting oxygen to the tissues for use at the cellular level. And ventilation is taking that CO2 produced in metabolism down at the cellular level and getting rid of it. That is, in the anesthetic world, the primary responsibility, which is different than the ICU world. Remember, in the ICU world, you're talking about patients that have been ventilated for days, weeks, even months on some of your very, very, very sick patients, right? Where in the operating rooms, what are we talking about? 2-3 hours, 10 hours, maybe?
Right. It's a shorter period of time.
Much. So we got to think about, really, it is life sustaining, don't get me wrong, but it's not in the fact of what we are used to in the ICUs. And in the ICUs, you're used to all these sick patients and all these respiratory disorders and everything that goes along with that, where in our operating rooms, a lot of the people we get in may be pretty healthy lungs, right? We're just trying to keep them relaxed for the anesthetic that we're providing, but we've got to give them oxygenation and ventilation during that time. So it really is paring it down to, why are we using this in our specific settings?
Okay. So when I first started even just understanding anything about the ventilator, two things that I picked up on was absolutely what you were saying with oxygenation and ventilation, but really just like the two separate modes, volume control and pressure control ventilation. That was just where I began. And do you think that's an appropriate place to begin this episode's journey as well?
Absolutely. And I think anybody studying, whether you are a nurse in the ICU looking at going to anesthesia school, whether you are a resident within a program, volume control and pressure control is where everything is fundamentally built off of. And if you can understand basically those two, then as we add in SIMV, as we add in pressure support or add in pressure control volume guarantee modes, if you can understand volume and you can understand pressure control modes, then everything builds off of those two modes, and we can teach you just about anything you want with ventilation and oxygenation according to the ventilators.
I like it. I like the positivity. Okay, great. All right. Well, then, you know what? Let's get rocking and rolling. Do you want to do volume control or pressure control first?
Let's go volume control first, because that's the one people are most used to, right?
Yes.
That's the one that really builds off, and it's the settings. Now, really, when you talk about volume control, you're just trying to deliver a tidal volume to a patient. So this is one that actually works really well when you look at it for patients that are pretty stable, don't have much, you could say, right? They don't have a lot of COPD, a lot of compliance resistance issues, that kind of things. But really, you're setting a tidal volume. And what the ventilator is doing is just delivering pressure through the endotracheal tube, through the circuit, through the endotracheal tube, just till it reaches that tidal volume. Obviously, with our newer ventilators, there's the compliance and resistance that is accommodated for with the newer ventilators, and the old ones it wasn't. But then it's just delivering that tidal volume to get those lungs expanded. And then when the breath's over with, obviously you're going to have exhalation that occurs, and you give it a respiratory rate for depending on to control your CO2 levels. That's just basic it. I mean, it's really not that difficult on the volume control, but it really works well when you're talking about just ventilating a normal patient, no big respiratory disorders, and is building that breath up. So this is one thing as I'm talking at different conferences about mechanical ventilation and with my residents, my learners themselves, it's slowly building that breath up within the lungs. So it's almost like a natural breath, gradually expanding those lungs till you get to the tidal volume you want. You finish, and then you have exhalation that occurs. So really the settings that you're primarily worried about is you're looking at the PEEP to hold the alveoli open at the end. You've got your tidal volume, your respiratory rate, and your FiO2. And that's the primary things. And really, FiO2, we're trying to have around that 30 or 40% just to keep them oxygenated enough to matter throughout the procedure. So that's really all you've got with volume control ventilation.
No, I like it. Yeah, because the way I started imagining it, and it really honestly did not start clicking until I was in the OR myself. But, I have a preset goal, and the ventilator itself is just trying to achieve that goal. And whatever pressure that it needs to use to get that goal is the pressure that it will end up doing, essentially.
Yeah. So I want two things that you just hit on that I really want to talk about.
Yeah.
And that is preset goals. So I want to talk about preset goals now, and then we're going to remain with preset goals as we talk later in this conversation. And since you said that I'd be around 50 more years providing anesthesia and talk about what we can do in 50 years with this. All right. But no, I want to talk about the future of it down the road too, and what I see best with preset goals. When we talk about preset goals, there must be preset goals. And I always say it this way is with the cardiac side, we always have preset goals, right? We always have an idea of where we want our heart rate to stay within, where we want our blood pressure to stay within. We think about those things in the hemodynamic side. And we're like, okay, we got to keep these parameters. But sometimes we forget we need to set parameters within the respiratory side. So in other words, where do I want my CO2 to be? So in volume control ventilation, I'm going to be adjusting my respiratory rate or tidal volume, depending on which one you want to do. And we won't get into the details on that right now, but you can adjust, your tidal volume and respiratory rate to reach your CO2 levels. Then you can adjust your FiO2 and your tidal volumes also, and maybe even your PEEP for your oxygenation side. So that tells you kind of how you can manage each one of those variables, but you got to have those variables and know where you want those variables to be.
No, that's an excellent point. And I'm excited to bring this up because I want your opinion on what you've seen with your students and even just, your colleagues. So when I've gone to a fair amount of clinical sites where it's just, at least when I first started, I was told, okay, you need to be doing ideal body weight when you're getting that, deciding that preset volume, right? Because I'm 5'6". Hello world, says my height. I am not 6'1". I am also not 4'8". The volume that my lungs need is not preset 500 cc's, which is basically where the machine will most of the time just start. And I do my best, I pick up things as I go, but I've noticed that there have been like a decent bit of individuals who just keep it at 500. And I'm like, this human is so tiny. I don't think they need it. Like, they don't need this much. We're going to pop a lung open if we keep giving them 500 cc. So when I first started learning with my school was really important. They taught me that you have to look at somebody's height because that gives you an idea to calculate what their lungs actually need. And when you're talking about these preset goals, that's where you want to start having that conversation with yourself before that patient comes into the operating room. So that way you're designing an anesthetic plan that's tailored to them.
Exactly. And so when you look at that, really, when I was in anesthesia school back in 04 to 06, this can kind of tell you how ventilation has changed over the years, which is important to pay attention to how it changes. Because when I was in anesthesia school, we were literally taught ideal body weight, but yet a lot of people still used the actual body weight.
Mm-hmm.
We were also taught 10 to 12 mLs per kg was your goal tidal volume, where now it is truly 4 to 6 mLs per kg. Because what we found out was we were creating a lot of barotrauma within our patients, or risking the creation of a lot of barotrauma in our patients and lung injury. And we did not need to be doing that overall. And you make a great point here, right? Let's just say, and I'm just going to throw a wild example out there, but say you got an individual that comes in for surgery in 2025, and they are 5'6", 205 pounds. Okay.
Mm-hmm.
They come back into surgery in 2026 and they're 5'6" and 305 pounds. Their lung volumes have not changed. Their lung size has not changed.
Correct.
The adipose tissue has, but their lung size have not. So really, this is an ideal body weight is what we should be putting and using for that 46 ml per kg calculation, because it doesn't matter how big I've gotten. It doesn't matter how, much adipose tissue I've put on or excess weight. My lung volume is still the same. Now, it may take more pressure to reach that lung volume, which we'll talk about with either pressure control ventilation or volume control. We can talk about it in a way, but the volume in itself should stay the same.
Right. Yeah, exactly. And so when I started putting a lot of that together, it just the whole concept really makes me think about, and it even goes down to even just breathing tube sizes too. This is not a one size fits all. I mean, the one size fits all may work for the socks in the hospital to be, even though we know it doesn't. So there's yellow socks in my.
Oh, I know what you're talking about. Yeah.
Yeah. So this isn't cookie cutter anesthesia. If we want to do the best for our patients, it all really does start with the calculations that we should be doing every single morning or between our cases, just to figure out, what does my patient actually need? what's too little and what's too much.
And that's how we stand out as practitioners, right? Is we put those little details into play. So we figure out, okay, well, let's say that, you're 5'6", and we have another individual who comes in, and generally for a female, you're using a 6.5 endotracheal tube. Well, you get a female that comes in, like you said, that's 4'8", and your little geriatric patient that's 4'8", and now she is 85 pounds because of the way that things happen as you get older. She may not have a 6.5 tube. She may be a 5.5 or a 6 tube. So it's the same with ventilation, right? And we'll get back on that topic, I guess. But it's the same with ventilation. Is you don't walk in and yes, the machines that we have, the anesthesia workstations we have, they're all programmed. They all have the systems that are programmed with a specific tidal volume, respiratory rate, and so forth. You can't just cut the ventilator on and say, bam, it's already done all the work for me. You literally have to go through those calculations, and you literally have to look at it and say, is this the right numbers, or are these the right settings for my patient that's sitting in front of me in front of the table to meet the goals of what I want as their parameters?
Excellent. Yes. Okay. And so for anyone listeners out there, we'll just play devil's advocate and pretend that nobody knows what ideal body weight is. So why don't we'll talk about that, and like, what's the down and dirty quick calculation for ideal body weight?
You're gonna get me on this one. I literally have to pull it up a lot of the times where
I'm
I'm doing this, but
sorry. Okay. So it is
she
the
is
height,
calling
right?
me out, guys.
I'm not calling you out. We're doing this together. We're together. Okay. No, watch. Baylor's gonna come get me if I don't get this right. So no, it's the height in centimeters, and it's different for guys and girls, right?
Yes.
So if you have a male, you want to do the height in centimeters minus 100, and then if it's females, you want to do the height in centimeters minus 105.
And you're going to see there are multiple types of formulas out there, right? Just like when you look at pediatric endotracheal tubes, there are multiple formulas out there. But when you look at, the formula like you were just mentioning, all of those come within a close range of each other, which is important. But yeah, you definitely need to use that ideal versus that actual body weight. That's really, really important in ventilation.
Excellent. Excellent. Okay, cool. All right. Well, then why don't we also lean into pressure controlled ventilation since we're on there? So just to kind of gather what we've talked about so far. So we've talked about volume controlled ventilation. It's delivering a designated volume that we have done the calculations for to our patient. And the ventilator machine itself provides the pressure that it needs to achieve said goal, being the volume. With pressure control, how I was always taught about it is that, now it's the reverse, where we have a pressure goal and we don't really want to over exceed that pressure goal. And whatever volume that is given with that pressure is the volume that the patient receives.
And that is exactly right. So you've got some great instructors there at Baylor. So really, though, when you look at it, it is very, very much the reverse of it. And you're dialing in, or you're setting your driving pressure. And that driving pressure is just what it's doing is just driving air through the endotracheal tube right into the lungs to expand it in a little bit of a different format. Like you said, you've got the sensors that are all set up with the circuits, the endotracheal tubes, and so forth. So in volume control, they can sense when 700 tidal volume or 500 or whatever is given. However, in this aspect, it's just doing a driving pressure. So let's say we put a driving pressure of 20 on the settings for this. So it literally is going to give 20 centimeters of water pressure through the endotracheal tube to open the lungs up. But instead of it doing it slow, like the tidal volume method does, this does it very quickly. So really what you get is a big burst of air through that circuit, through that tube, expand the lungs really quickly. So it really allows the lungs to open up fully at this point in time. Now, the question is going to come in a little while is, why don't we use that for everybody?
Right.
Part of that for me is I don't, because it's not the natural form of lung expansion. Therefore, it becomes very stimulating to a patient, especially if you don't have muscle relaxant on board very well. So
Yep.
it could cause them to actually buck, because it's a very stimulating method. Plus, that's not the natural way our lungs are supposed to do. So if we've got injuries, right, or if we've got lungs that are kind of weak tissue, you can actually blow a lung in this method. Now, you're right in the fact also that the tidal volume changes, because depending on compliance and resistance, The tidal volume is going to change because the driving pressure is going to stay the same, but the tidal volume is going to either go up or go down depending on resistance and compliance. So if you don't mind, I got a quick example for you.
No, let's do it.
All right, so I will never forget this. If any CRNA my age of 25 says that they have done, and obviously I'm not 25 years old, but any of them says
Okay,
that
neither am I.
they have not probably done this in their career, it's probably, they just haven't paid attention maybe.
Right.
But we do laparoscopic cases all the time, right? And this is talking about just straight pressure control ventilation modality. So we would take our patient, we'd put them to sleep. We have them on a volume control method. They're getting 500 cc tidal volumes. You've got a peak inspiratory pressure because you're using volume control. So you got a peak inspiratory pressure of around 18, just for quick numbers. And then all of a sudden they insufflate the abdomen and you start going in awkward positions, right? So what happens is now, because you've insufflated the abdomen, you've changed the intrathoracic pressure that's also been transmitted up from that insufflation of the abdomen. Now you've got a problem with compliance. Now the lungs can't expand as well, right? So now what happens? Your tidal volume drops to 350 because your peak airway pressures are going out the roof and they've alarmed off and everything else, right? So your peak airway pressures are going up to try to compensate. They couldn't go up high enough to compensate, so your tidal volume drops. So what do? You switch over to pressure control method because pressure control ventilation can actually allow for higher tidal volumes at lower driving pressures than a volume control method can. So now you switch over to a pressure control method because you have those changes in compliance and so forth. All of a sudden, at the very end of the case, what do? Up, I'm done. Trocar's out. Now you're on a pressure control with a driving pressure of around 25, say 30, and you were getting a 500 cc tidal volume while they were insufflated. Now that they've changed the compliance and they've increased compliance in this case, right? Because they've taken the insufflation out. Now you got a 1200 cc tidal volume because it's still using that 25 driving pressure. So now you're at risk of barotrauma. So that's why you also have to pay very close attention as you're doing all these vent mode changes.
No, definitely. And that's certainly something that early on in my practices that I did so myself, and I'll 100% admit to that. And, I had my CRNA tap me on the shoulder and be like, look how much that's changed. And I'm like, oh my Lord, that is not the volume my patient needs at this moment. You don't want to fall asleep at the wheel. You know what I mean? Like we are in control of our patient and just strictly paying attention to what's going on and know your baseline numbers. So since we're kind of on the topic, my two big questions that I'm thinking about that I think would be really great for our listeners here is, when is it appropriate to use pressure control? And we are basically already talked about one of them. So if there's any other like patient population specific individuals, and then is there a certain pressure number that we don't ever want to like exceed beyond?
Yeah. So I'll be honest with you, and we're going to talk about this mode, I'm assuming here in a few minutes, is pressure control volume guarantee.
I love that mode.
So I never use pressure control ventilation anymore because I'll use pressure control volume guarantee as a pressure control mode.
Right.
And we'll talk about the nuances of that and how it works. But if you're talking about using a pressure control technique, which is either pressure control ventilation or PCVG, those are where you're going to have compliance changes that are going to, increase. You've got a lot of increases in compliance decreases in compliance and increases in resistance, where it's hard to ventilate a patient. Your severe ARD, severe COPD patients, these are ones where you really want to control how much pressure is being inserted, right? Or how much driving pressure is being used. Those will be kind of those cases. And again, as I mentioned, you can sometimes get with a lot of these patients, you can, with the way the mode works, and I wish I could do pictures here because I've really got some really good ones that I use in conferences, is showing how it pops the lungs open, right? And does it as a good pressure. And you can get lower peak inspiratory pressures by using pressure control than you can by using volume control in these patients that really need that driving pressure, which usually I won't go above 40. 40 is my cutoff. No ifs, ands, or buts. If I start getting above 30, then I'm like, what do I need to do here? Am I needing to change PEEP? Am I needing to change respiratory rate? Am I needing to change my I to E ratio to still maintain that oxygenation and ventilation I want and not go above 30. But once I get above 40, I'm like, okay, now we really got to assess what's going on. Do I have a tube that's kinked? Do I have a plug in there? What else is going on within the system? Do we need to give bronchodilators?
And this is honestly where I remember my professor, and I'll give her a shout out, Dr. Bullerwell, who is my academic advisor. She told me from the very beginning that as soon as you intubate your patient, yeah, you're looking at your CO2, but you also are looking at your peak pressure. You're looking at every single number because you just want to know where you're starting, because you really want to be like it's kind of like with blood pressure, where it's like being within that like 20% of the baseline sort of scenario. So if now all of a sudden the pressure's been okay and now we're like 42 and you're like, whoa, where did that come from? Has it been we've been gradually going up to 42, or is it a 42 out of nowhere? So like it just helps you organize your thought process on how to fix it for our patients.
Absolutely, because you mentioned it earlier, we're not all the same. 5'6" does not mean that everybody is the same weight, and not everybody's starting off with the same actually parameter. So again, you got to have that starting point, because if you don't have the starting point, then you don't know what your variations can be, right? You don't know. Like I said, you put it in a tracheal tube in me, and I'm 5'6", my starting peak airway pressure may be 18, yours may be 12.
Mhm. Yep. Right. Exactly. When I started feeling like I was getting, I hate the word comfortable in anesthesia, but started getting used to the ventilator and playing around with it and understanding it just better as a whole, is when it wasn't just for me understanding just like the basics of what that ventilator mode is giving me, but how I can change different things about it. Like you mentioned before about changing the PEEP in order to reduce our pressure to our peak pressure. So can we dive in a little bit right there of, okay, so we have the bread of the sandwich, but how can we make our sandwich kind of fancy? And where it's just like maybe this patient does require a pressure mode of ventilation, but we can't be way up in the 40s or near 40. We need to be down a little bit farther. What other things can we do to help it work for us?
Right, we're looking at oxygenation and ventilation. Everything goes right back to that, right? So you are trying to get larger tidal volumes because you're trying to oxygenate them better, right? But you can't do that because if you go higher on your, especially if you're looking at a volume control method or in a pressure control method, your driving pressure or your peak inspiratory pressure is getting too high and you're not comfortable with it, you can add some PEEP. Now, obviously, you have to be careful because once you start getting above around 8 or 10 of PEEP, then you got to worry about the intrathoracic pressure on the heart, and you got to worry about the cardiac output decreasing a little bit and so forth, especially if you've got patients that are cardiac issues. But really, when you look at it, you can start adding a little PEEP. So in other words, if my biggest issue is I'm wanting to expand the lungs, and why am I trying to expand the lungs? I'm trying to expand the lungs really well so that we can get the alveoli to pop open so that we can have good transfer of oxygen across the alveolar capillary membrane. Well, if that's not happening because I can't get the lungs open big enough, right? Because of the tidal volume is not going to be large enough unless I go really high on my inspiratory pressures, then add PEEP. PEEP's going to keep those alveoli open. That's going to give you the ability to now improve that transfer of oxygen, that movement of oxygen across the alveolar capillary membrane to, again, meet your oxygenation needs, right? What if you're having problems with CO2? Well, now you talk about CO2 issues. You can change your respiratory rate, but what is CO2? When do we get rid of CO2? It's on exhalation. So change your ID ratios. If you change your ID ratios and give a longer exhalation time, then you can actually improve, right? You can improve the movement, or you can improve the exhalation time and lengthen it. You're going to get rid of more CO2. If you're having problems with oxygenation, you can actually increase your inspiratory time. If you increase your inspiratory time, then you've got more time for oxygenation, for more oxygen to be breathed in, to be delivered. And so you got all of these changes you really can make if you start thinking about, okay, when I make this change, what is it truly going to do for my lungs? And what is it going to do when I look at exchange of gases across that alveolar capillary membrane, or when I'm trying to exhale?
Right. And this even goes beyond just the general maintenance phase of anesthesia, but even when you're starting to get into the active emergence too, where it's like, okay, now I want to build up that CO2.
Hmm.
Sure, you can drop your respiratory rate, but you can also play with the volumes too.
Absolutely. So it's really, when you look at the CO2, what is CO2 maintained by? I mean, you really, in the anesthetic world of what we're doing, is maintained by your minute ventilation. And what is your minute ventilation calculation? That is tidal volume times respiratory rate. So it doesn't mean that you have to change your tidal volume to do that. You can change your respiratory rate. Or if you're at a respiratory rate and you don't want to change it, you can change your tidal volume. So it just really, it's all about, when you're looking at the CO2 side of this, it's about minute ventilation.
Yeah, absolutely. Okay, great. Well, then you know what? Let's dive right into, I guess, our favorite. I feel like we've bonded over this.
Yes, we have.
This ventilator mode. I love the pressure control volume guaranteed mode. It is, put that on my gravestone. It is just near and dear to my heart. So why don't we dive into that for a little bit?
So it really is my favorite mode in the right situation, obviously.
That's fair.
When I talk about it being in the right situation, this is in situations where I feel like there's going to be changes that are occurring throughout the case in compliance and resistance. And I really want to maintain a pretty standard level of ventilation for the patient, right? So in my healthy patients, I use SIMV volume control methods. And we'll talk about SIMV. But in my sicker patients and those that really need some kind of pressure controlled ventilation mode, I use the pressure control volume guarantee. And a lot of people don't realize this, but technically it's an AI mode when you start thinking about it, because it's micro learning that takes place in between every breath, right? And therefore it's running through an algorithm, and it's actually an AI mode of ventilation.
Oh, man.
I just blew your mind, didn't I?
Yeah, you did. Because my dad just told me the other night, he's like, I'm so proud of you. He calls me Big Girl. That's his nickname for me. And he was just like, you're in a field that AI can't touch. And now you just said this to me. And now my my mind's been blown.
Yeah. I just got through doing a presentation. It was actually the very last presentation at the annual Congress. And it was AI and anesthesia and the future of AI and anesthesia.
Frightening.
So I could talk about that for days. But really, when you look at pressure control volume guarantee, what people don't understand about the mode is it delivers a pressure control technique, but using volume control settings. So you just take your patient that you have your ideal body weight on. Let's say, let's go back to that 500. Let's just say 500 cc's is the ideal tidal volume that we want to reach for this patient. But we know they're going to have compliance and resistance issues. So really what the ventilator does is as soon as you turn the ventilator on, all right, let's leave all this other settings the same. The FiO2, the PEEP, all of that, we understand all of that. Where we're seeing our change here is where we're seeing the change in the mode of volume control versus a pressure control. So the first couple of breaths it delivers is a volume control mode. So really what it's saying is, all right, I'm going to give Olivia a 500 cc tidal volume breath here. And I'm going to determine that if I give her a 500 cc tidal volume breath for 2 or 3 breaths, what is the average peak inspiratory pressure or peak airway pressure I have with her? Now, in the next breath, I'm going to flip, and this is what the ventilator's doing. I'm going to flip over to the pressure control mode, and then I'm going to use what I just calculated from her average peak airway pressures. I'm going to use that or something very similar based on the algorithm as now my driving pressure for my pressure control mode. Now, when you have changes in compliance and resistance that occur, what happens is when those changes occur and you get that tidal volume that gets outside of a standard deviation that is calculated by the machine, it then flips back into volume control mode and said, all right, well, something's off here. I'm going to flip back into a volume control mode. I'm going to give Olivia a couple more breaths, and I'm going to figure out now what is her new average peak airway pressures.
That's crazy.
And then after a couple of breaths, it's going to flip back to pressure control mode using that new calculation it just had is the new driving pressure.
Wow.
And so it's doing that throughout the entire case. And so when you have patients that you insufflate the abdomen or that you put on their head or that you put on their neck in steep Trendelenburg or anything like that, right? Then you're going to see that changes and the machine automatically makes those changes for you.
I had no idea that it flipped back and forth between the two. But and the next time, and I'm in OB right now, so I feel like I have not put a patient on a ventilator in so long. But for my next clinical site, I'll pay attention to that to see if I can, because I guess you can't. Can you tell when the machine's doing that?
Yep. So if you're looking at your waveforms, you'll be able to tell which way that it is ventilating, because you'll see In your volume control, you will see it have a little bit of an arc to it, right? You've probably have noticed that before. Gets a little bit of an arc to build up, and then you see your exhalation that occurs. In your pressure control is pretty much because of the rise in pressure that is so dramatic so quickly with the way a pressure control breath is driven. It's a very rapid upstroke. Then you see your plateau, and then you see your exhalation phase. So you literally will see it changing when it needs to. You'll see it changing between those two modes.
That's really crazy. Wow. All right. That's definitely a new one for me because wow. Okay, cool. All right. Well, I love that. All right. Let's talk about okay. So what about SIMV? Because I know that's something that you mentioned before too. And I do know that this, at first I didn't really understand the synchronized with the ventilator plus the patient, but now I feel like it's a very useful mode to have when you're even just with like an LMA, you're trying to get your patient back breathing and just like figure out where they are. Like it's just so useful.
So I'm gonna make it very, very simple with SIMV. Let's
I
break
like it.
this down and make it very simple. So there's an SIMV pressure control ventilation and an SIMV volume control ventilation on a lot of our machines, right? So all SIMV is, it's an upgrade. It's an upgrade to volume control, and it's an upgrade to pressure control.
Okay.
All the upgrade is adding pressure support.
Huh.
And what does that mean? That just means anytime a patient takes a spontaneous breath, they're going to get assistance from the ventilator. So the ventilator is going to recognize it, whether it's from flow, whether it's from pressure, whatever the sensor for that particular ventilator and machine or whatever is set in there is literally going to say, okay, based on what I'm seeing in flow or what I'm seeing in maybe a negative inspiratory force here, it looks like Richard's trying to take a breath. So I'm going to assist with whatever pressure support that Olivia has put on the machine to assist me. So in between the mandatory breaths that it's giving, so say 10 breaths per minute, right? In between those 10 breaths per minute, if I go to take a breath for some reason, if I don't have muscle relaxant on board, I go to take a breath and a spontaneous breath, I may only get a 50 cc tidal volume breath. But now that you've added 10 of pressure support to me, now I may be getting a 250 cc tidal volume breath. So that's all it's doing is assisting that spontaneous breath that is taken outside of what the ventilator is giving to you mandatory based on the settings that you have.
Yeah, definitely. And I find this as a very useful tool when I'm working towards weaning a patient off the ventilator too. Typically speaking, we just want to standardize it for me as we'll start off with you like the volume control, pressure control, or the volume control or pressure control volume guaranteed just to kind of start with. But then as you know, we're starting that closing process and I know that I'm not going to give any more paralytics and we're closing whatever surgery we're doing. I will put them on that SIMV. I want to figure out, okay, where are we? Where is my patient in the grand scheme of things? Are we even breathing on our own at all? Are we overbreathing? Are we in pain? Like, there's just a lot of information that you can really gather from it. And even then, and I'm totally blanking on what I do because it's turning down, like it usually is at like 2. You know how like you could turn down?
So you got your
Yes, yes.
trigger. You have your trigger that's associated with it, right? And that's the one thing that you have to be careful with is the trigger side of it, because you will have people that will decrease or turn down the trigger on it, which means basically instead of me having to produce, so say the trigger is based on force, right? Or flow, either way. You can go either way. Instead of me having to produce so much negative force for the sensor to actually recognize that Richard's trying to take a breath, a lot of people in the very beginning will turn those down so that the machine is more sensitive per se, and therefore it recognizes quicker with less effort by Richard that he's trying to take a breath. So you can change that trigger in there. You have to be careful sometimes. We don't have time now for another story on that, but I'll tell you one later on off air. But because you could actually change it to where the machine is getting fooled and it looks like the patient's breathing, but they're actually not.
Ah, okay, yeah, because the way I usually do it is I'll just do plain SIMV with the standard trigger, which I believe is around 2 or 3,
These are out too.
depending on the yeah, and then I just take a blank look, okay, what is my patient doing? If they look like they're sort of doing something, I'll walk the trigger down just a little bit and then give the patient just a little bit of time, and then I walk that trigger back up because I like the way I like to think about it is when my patients in the ICU we're trying to get them to meet that criteria for extubation. Part of that criteria was that you have to get more than -30. Explaining this terribly, but you know how like with the patient we ask them to like suck in air and breathe through the tube.
So it's the NIF.
Yeah, the NIF. That's right, the NIF. I think of it as like a similar means to that, where it's just like how much strength does this patient have in order to initiate their own breath and draw in air on their own?
And that's exactly what you're doing as you change the pressure support in it too. But yeah, it's definitely when you're looking at that trigger that you're talking about, and the way you're talking about utilizing this as you're weaning a patient towards the very end, this is the ideal. For me, this is the ideal. So I never use straight up volume control methods anymore. I always have my patient on SIMV volume control because just in case something happens in the case, muscle relaxant wears off and they go to take a breath or something like that, it is supported. Because if they're not, then the pressure support's not going to matter. It's not going to hurt anything. They're just going to get straight up volume control method. So I always use the SIMV when I'm doing those. So it's either usually for me SIMV volume control methods, pressure control volume guarantee if I'm using pressure, if I'm using a pressure mode technique, and then kind of getting towards the end of this, I guess, is then the pressure support, right? The PSV Pro that you can use when you've got your patients also spontaneously breathing and no longer need assistance for a mandatory breath from the ventilator in itself, or things like LMAs and so forth.
Yeah, no, definitely. Yes, because after that SIMV, then I work them into that pressure support mode, and I try to, if the patient can tolerate it, weaning down also my PEEP because I'm trying. Once I take the breathing tube out, I want to make sure that they can handle ventilation on their own. Because no way, Jose, do I really want to go back into that intubating process. I want to make sure that they can do it. So yeah, I walk them down, I'll put them on the pressure support, I'm seeing what they're doing, and then at that point, I'll flip them back into their own manual ventilation, see what they're doing, and then at that point, I'm also getting a good idea of, all right, how much is my patient actually breathing? Are they in pain? And it's just like this whole assessment process that's going through.
So I'm going to challenge you just a little bit here at the very end. All right. A little bit of a different thought process here at the very end and challenge you on it.
Okay.
So the way you're talking about is the way we have done it for years and years and years, right? You get them on some pressure support, then you turn them off of the pressure support, let them manually ventilate on their own with no pressure support or anything. And let's see, are they taking 50 cc tidal volume or 250 cc tidal volume or 500?
Right.
However, the one problem with that, or the one caveat, I wouldn't say problem, but the one caveat I have that you can go with that is once you turn a patient off, it does not take very long before atelectasis starts occurring.
Oh.
So once you turn the patient off the ventilator and they have to take their own breaths and they're taking very small breaths, atelectasis starts occurring immediately. So really what I do now is I will put them on pressure support mode. And I've seen this from other people too, is I put them on a pressure support mode and I look at how much my pressure support is on them. So if I've got them, for example, I want to get them to a 350. Towards the end, I want to get them around a 3 ml per kg tidal volume towards the end. And I say, okay, it takes about 15 centimeters of water pressure to get them to that on the pressure support while they're spontaneously. Well, I'll start titrating them back just like you do, right? As they get a little bit stronger, I'll titrate it back till I get to a pressure support of 5. And then I'll leave them on a pressure support of 5 just to have them keep those alveoli open as long as I can keep them open. And then right before I'm extubating them, then I will turn them off of the ventilator altogether and extubate them. So I have proper, and as much ventilation and oxygenation to that patient up until my very last minute. Because if they're only on about 5 of pressure support, that's not a lot at all. And therefore, if they're on 5 of pressure support and they're now pulling 350 tidal volumes, where earlier they were on 15 of pressure support and they were getting 350 tidal volumes, I have personally seen how much now that I've been able to dial that down and still see them getting stronger throughout because their tidal volumes aren't really changing.
It's so interesting that you bring this up because I remember when we extubated in the ICU, we extubated them on pressure support. And I remember being in one of my clinical sites early on in the clinical portion of my learning, and I had a preceptor, and I'm not going to say whether it's a CRNA or an anesthesiologist, that part doesn't matter, but they were saying to me that you cannot extubate on pressure support. That is incorrect, that you need to extubate them when they're just on manual ventilation. And so I'm glad that you're bringing that up, because it's proving that wrong. And I knew about atelectasis, but I didn't think about how quick it could occur.
Doesn't take but about 2 to 3 breaths of spontaneously ventilating at a low tidal volume, and you're already getting an atelectasis. And then the other aspect to consider with that is that when you're taking them over to the PACU, they're not always a one-on-one care in the PACU. So you want them to be optimized to last as long as they can over in the PACU and being able to wake up and then getting their full lung function. So I always keep them on pressure support until the very end, so that, again, I can maximize oxygenation by minimizing atelectasis until the very last moment.
And I'm sure that comes very, very handy for those that are more at risk for atelectasis. And I'm just strictly speaking, talking about those with, a larger BMI or more just tissue also, and they just don't have a really good FRC either.
And your elderly patients who their respiratory muscles are not as strong either. So there's a lot of patients that it was very, very beneficial on.
No, that's awesome. Okay, wow. No, thank you for challenging me, but then also educating me at the same time. I do genuinely appreciate that. Well, we certainly talked about a lot. I guess, should we talk about real quick, like where we see AI even going? Can I have like a little bit of that?
So we're already seeing some of that. You got the Hamilton ventilators that are out there that are actually doing a little bit of AI technology behind them. We talked a little bit about pressure control, volume guarantee, but where I see this in the long run, and obviously AI will not replace CRNAs. There's no way that I feel that it can. I think AI is a tool that can enhance the care that we're providing and enhance what we're doing for our patients, especially if used properly. But where I see it in the future is I really see us being able to say, okay, I want to have a entitled carbon dioxide level between 32 to 36. I want a saturation SpO2 above 95%. I want a peak airway pressure less than 25. And I think you see where I'm going with this, is basically we could put all of our parameters in there, and then the ventilator would start making its own adjustments to meet those goals for us. Now, obviously, we will need to be there for those things that are outside of what algorithms can figure out and what algorithms will recognize. But I see the future of this being able to say, hey, here's my parameters. Here's where I want the patient. Here's a little bit more information behind them, which we'll be able to bring in through all of the AI algorithms, and it start to manage a lot of it for us.
No, I love that. And we're honestly already even seeing it right now with the low flow anesthesia aspect of it. And that's something that I'm even big on too. So, but thank you so much for just talking with me about all of this. And ventilator was not only just a really great review for me, but also proved to me that, I can actually talk about it. It's not just, something that makes me feel like I have like just my tongue twisted in knots. But this has been a really great review. And I do genuinely believe that there are a lot of SRNAs and even CRNAs out there that will find this episode really useful.
Well, thanks for having me. As always, appreciate what y'all are doing for the community. And I wish you the best as you move forward into the career.
Thank you. Yes. Hopefully maybe we can see each other in Charleston.
Absolutely.
Want to be the voice of the next season of Grade 1 View? Well, we're looking for new hosts for Season 2, launching in 2026. If you're a CRNA student or resident with at least 12 months left in your program, this is your chance to grab a mic and shape the conversation. Apply by November 1st at aana.com/G1V, or just check the description of today's show for a link. Let your voice be heard on Grade 1 View.